Thanks, Richard. It's a pleasure to introduce Antonio to this group. He's working with us through this summer as the first year of his BSc Med program. Antonio's had an interest in the area of food allergy and is specifically addressing a very topical, important, and increasing problem, and that is the issue of peanut allergy in young children. His title, as you see, is to try and understand the relationship between maternal peanut consumption during pregnancy and the prevalence of peanut allergy in a birth cohort. Antonio, you're up. You're away.
Okay, thank you, Dr. Becker. Good afternoon, everyone. I've had the pleasure of working in the Allergy Clinic this past summer, and as you can see here, the title of my project is Assessing the Relationship Between Maternal Peanut Consumption During Pregnancy and the Prevalence of Peanut Allergy in a Birth Cohort. So what is my objective? My objective is to determine whether or not maternal consumption of peanut during pregnancy has, or does not have, an influence on the likelihood of the infant developing a peanut allergy. So you're thinking, okay, well, what is a peanut allergy? Peanut allergy is characterized as typically lifelong, often severe, and potentially fatal. Allergic reactions related to foods are triggered by certain antigens that are found in the food. In general, allergic reactions to food occur as a result of an IgE-mediated process. In order for an allergic reaction, also referred to as a type 1 immediate hypersensitivity reaction, to occur, an allergen must first influence an immune system to produce IgE. Immature B cells possess either IgM or IgD on their membranes. Upon the primary exposure to the immune system, the allergen will bind the immature B cells, as well as stimulate Th2, also referred to as T helper cells, to produce interleukins, such as IL-4 and IL-13. Interleukins will stimulate B cells specific to the allergen to switch from the immature B cells to the IgE-producing plasma cells. Mast cells, basophils, and eosinophils are then coated by the IgE antibodies that have been produced. Upon secondary exposure to the allergen, IgE will react with the allergen, causing the release of histamine, as well as the generation of prostaglandins and leukotrienes. Now, after these mediators are released, this will lead to the development of signs and symptoms, such as hives, swelling of the lips and eyes, vomiting, nausea, abdominal pain, shortness of breath, wheezing, coughing, and sometimes reflex tachycardia and hypotension, causing people to pass out. So some important epidemiology here is the peanut allergy prevalence in different parts of the world. In Canada, as you can see, 0.71% of adults were seen to have peanut allergy in a 2010 study, whereas children were 1.68% of children were seen to have a peanut allergy in the 2010 study. In the United States, 1.4% of adults were seen to have peanut, tree nut, or peanut and tree nut allergy in the 2010 study, where 2.1% of children were also seen to have the same allergy. In Australia, 3% of infants were seen to have peanut allergy in the 2011 study, whereas in France, between 0.3% and 0.75% of the general population were seen to have a peanut allergy. Denmark, 0.4% of adults were seen to have a peanut allergy, while 0.2% of 3-year-old children were seen to have the same allergy. And in Israel, this was the lowest value that I found while doing my research, was 0.04% in infants and young children. So the prevalence has changed over time. The Isle of Wight, which is found in the UK, there were two cohorts that were studied in the years of 1994 and 1996, as well as 1989. There was a twofold increase in reported peanut allergy. It was 1% in the 1994-1996 cohort, but it was only 0.5% in the 1989 cohort. Whereas there was a threefold increase in reported peanut sensitization, with 3.3% in the 1994-1996 cohort, as well as compared to 1.1% in the 1989 cohort. Canadian values, as you can see, have increased slightly from 2000 to 2010, but in reading and in researching, these values have plateaued over time. versus the United States, where the value, as you can see, from 1997 to 2002, essentially doubled. And where from 2002 to 2008, it almost doubled again. So again, you can see a more significant increase in a different part of the world. So what we're looking at is maternal consumption of peanuts. Well, what exactly are the dietary recommendations for pregnant women? In the 1990s, in many countries, such as the UK, recommendations were for women to avoid peanuts during pregnancy. In 1998, the UK government published a report which in part recommended that mothers avoid peanut consumption during pregnancy and breastfeeding if they had a history of atopy, or if the unborn child's father or sibling had a history of atopy. An important question is, what exactly is atopy? Well, atopy is also referred to as allergic disease, and this gives rise to allergy in people. Examples of atopy would be allergic asthma, allergic rhinitis, food allergies, as well as atopic dermatitis, which many people might more commonly, a subset they would know is eczema. In 2007, there was a study performed. It was a follow-up cohort study of school-age children born from 1999 to 2000. And this were in 2 years after the recommendation was put in place in 1998. And this study found that there was neither a positive nor a negative effect on the prevalence of peanut sensitization or peanut allergy as a result of the 1998 recommendation. Present day, the National Health Service in the UK recommends that pregnant mothers can eat peanuts unless they are allergic to them or a health professional advises them not to. And this advice is based on the fact that there is no clear evidence to show that changing the diet and restricting peanut consumption doesn't show that it will have an effect on their children developing a peanut allergy. The American Academy of Pediatrics also echoes the sentiment. They also found that there was no conclusive evidence to support any dietary manipulations or restrictions during pregnancy, but previously the AAP guidelines did suggest that pregnant mothers avoid peanuts, but evidence has become available to suggest the contrary. This brings us to the child study. So what is a child study? It's a Canadian healthy infant longitudinal development study. And as you can see here, the primary objective of this national longitudinal birth cohort is to determine the roles of a range of environmental factors and their interactions with genetic and host factors in the development of allergy and asthma in children. Methods. What is the study design? It is a general population-based prospective cohort. The primary outcome is physician-diagnosed asthma at age 5, as the study is slated currently to be 5-year, as children are followed from, pregnant mothers are followed from pregnancy to childbirth all the way to age 5. The intermediate outcomes are food allergies, atopic dermatitis, allergic rhinitis, and preschool wheeze. Pregnant women were recruited after their first trimester, mainly between 18 to 36 weeks of pregnancy. There are 4 sites across Canada, one right here in Winnipeg, Edmonton, Toronto, and Vancouver. The total recruited in the entire country was 3,308, and in Manitoba, there are 1,041. Anyone who works with a child study will tell you that there are dozens upon dozens of questions asked in the questionnaires, but here are some relevant ones to the information that I've studied. Maternal consumption of peanut during pregnancy, age of introduction of foods, as a possible route of sensitization, as well as the duration of breastfeeding, another possible route of sensitization. With that being said, although we have a plethora of information available to us, there are limitations of our available information. We do not have specific information asking mothers about their peanut consumption during breastfeeding. However, we are still taking breastfeeding into consideration as a possible route of sensitization. In addition, we do not have information on the amount of peanut present in a home, so that's considered environmental home peanut exposure. There was a study published by Fox et al. in 2009 that showed a dose-response relationship with peanut in the home and the development of peanut allergy in infants. And it was found that sensitization appeared to be promoted when there were high levels of environmental exposure to peanut during infancy. A large part of what I did this summer was a literature review in order to determine what information was out there relating maternal consumption of peanuts and peanut sensitization. There were 2 studies that did show a relationship by Marion et al. In South Africa in 1999, as well as Sicker et al. In 2010 in the United States, where a relationship was shown between maternal consumption of peanut during pregnancy and the outcome of a child's development of peanut sensitization. In comparison, there were 4 studies where they showed no relationship between maternal peanut consumption and peanut sensitization development. Terry et al. In the Isle of Wight in 1996, Black et al. In the United Kingdom in 2003, as well as Hoorhane et al. In 2007 in the United Kingdom, and Binkley et al. In 2011 in Canada. And as you can see from all the different studies, there's a wide range geographically of peanut allergy being studied all over the world. So what's my hypothesis? Well, my hypothesis is that there will be no association found between maternal consumption of peanut during pregnancy and the development of peanut sensitization in an infant. A sub-hypothesis to that is that there will be no association found between maternal consumption and peanut allergy in an infant. So you must be thinking, well, what's the difference between sensitization and allergy? Sensitization is the demonstration of allergen-specific IgE and the production of allergen-specific IgE in the body, whereas allergy is a clinical response of exposure to a substance against which we produce allergen-specific IgE. A good example of this is a study of infants in Melbourne, Australia, where the prevalence of peanut sensitization was 8.9%, which was based on skin prick testing. And skin prick testing is simply where a substance with the allergen in question is taken, a plastic prick, if you will, is taken and pricked on the skin where the development of a hive occurs. And any hive greater than 3 millimeters in size, where the wheal size is greater than 3 millimeters, is considered clinically significant for sensitization. Whereas the prevalence of peanut allergy, as you can see here, was much lower at 3%. And that's based on an oral food challenge. Now the oral food challenge is quite interesting. What occurs for the oral food challenge is the patient comes in and consumes the food or allergen in question in increasing amounts at a single period of time at a single location. There are 3 outcomes to a food challenge: positive, negative, inconclusive. Positive food challenge is objective signs, 1 or more, where 3 or more non-contact hives will occur. They last for at least 5 minutes, swelling of the eyes and lips, vomiting, and any circulatory or respiratory problems. And a positive food challenge means that an individual is allergic to a specific food in question. Negative means that they can tolerate it and that they ate the increasing amount of food and with no reaction. And inconclusive means that a patient did not want to eat the food and therefore we have no results as to whether or not they have the allergy. Future plans: information will be collected next summer, in the 2nd and final summer of the BSc Med project. These are the different information that we're going to be looking at: skin testing results from the 1st year and 3rd year visit, and that will give us an idea of sensitization. Whereas the 1-year and 3-year child health questionnaires, parents are able to self-report their child's allergies, and that will help us to determine peanut allergy, prevalence of peanut allergy, and all of these will allow us to determine whether or not maternal consumption of peanuts during pregnancy leads to sensitization of peanut or peanut allergy in infants. Thank you for your time.
Thank you. There are some questions from the audience. I have a question.
Sure.
How do you think this works?
The mechanism?
Yeah.
To be honest, I haven't done a lot of research into it. That's something that I should be looking into.
What do you guys talk about in the lab? What do you think is going on like you have some indication that it might be an issue, and you have other studies that say, well, it's probably not an issue. So what's the rationale to think that it might cause?
Well, the interesting thing is that most of the peanut reactions to peanut occur in the first exposure. So my thinking is that there has to be some way for the infant to be exposed to it initially, whether that be in utero or in the first few months of life or first years of life. So it might be through breastfeeding, it might be through the home exposure that I spoke about, or it truly might be through the pregnant mother's consumption during pregnancy. And as I mentioned about the mechanism of the allergy to the primary response and secondary response, there has to be a way for that primary response to occur. Because a lot of the children are not eating the peanuts first. Right? So it has to be through a different route other than their own consumption.
Okay. Any other questions?
Is there a genetic predisposition for peanut allergies?
I don't know the exact answer to that, but as I spoke about the A to B, it's a syndrome and you're prone to allergic diseases, and food allergies is one of them. And a bit of reading that I did do was that in A to B there is a genetic predisposition to A to B, so in that sense there may very well be, but I don't know the definitive answer to that.
Anything else? Okay, so we have a little tech.
Oh.